Hi, hello, good evening, everybody. Welcome to Stanford Care's monthly community health talk series. My name is Kevin Chang. I am a clinical assistant professor in the Department of Medicine at Stanford University School of Medicine, and I'm pleased to bring you this series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. I am very pleased to welcome Dr. Ann Xing, who will speak on cancer in Asian Americans, epidemiology and prevention. Cancer is the leading cause of death among Chinese, Filipino, Korean, and Vietnamese Americans. For certain Asian ethnic subgroups, there are also variations in cancer risk. This seminar will highlight high-risk cancers for several large Asian American subgroups. It will also touch on cancer-related risk factors and the importance of age and risk-appropriate cancer screening. Dr. Ann Xing is a professor of medicine in epidemiology and population health at the Stanford University School of Medicine. She is a molecular epidemiologist whose research focuses on investigating cancer etiology and prevention through population-based epidemiologic studies. Dr. Xing published more than 370 peer-reviewed papers and has mentored more than 90 junior investigators. She is an absolute leader in the field of cancer epidemiology. And with that, I will turn it over to Dr. Xing.
Thank you, Kevin, for your very nice and warm introduction. Really appreciate it. And so let's just get started. I'm going to share my screen. So this is Cancer in Asian Americans, Epidemiology and Prevention. So I want to just highlight that today we will be talking about epidemiology, that is our pattern of disease, and prevention. And so I'm not a clinician, so I will not be able to talk about treatment. Okay, so let's get started. And thank you for coming, and thank you for your time. Really appreciate it. I first just want to say happy Lunar New Year 2025, and I hope this year brings you happiness, safety, and also fulfillment. So usually when we talk about cancer epidemiology, we talk about who, what, when, where, and why. Who will be, who are getting cancers, what kind of cancer, when do they get it, when should we have the prevention or early detection, and where are the cancer, where are the hotspots, and why people are getting cancers. And today I have 45 minutes, so I won't be able to go through all of these. I teach cancer in Asian Americans at Stanford, so today I condense my 10 lectures into 40 minutes for you. Hopefully it will be interesting to you. Asian Americans is a very large group. We actually have more than 40 plus ethnic subgroups. So cancer is also a very large collection of diseases. So it's not one size fits all. So whatever we talk about today, you just need to think about it as overall sort of generalization, okay? So there are 40 plus Asian American subgroups, but the 5 large groups are Chinese, Asian Indians, Filipino, Vietnamese, and Korean together comprise 76% of the groups. And then the rest of the groups usually just 5%, 2%, or 1%. But still, it's also very important to have this aggregated data so we can understand cancer pattern in each group. Cancer, I already mentioned, is actually a collection of many, many different diseases. It's a cancer of different organs. Within each organ, there are actually different subtypes of cancer, different histology. So the etiology, the risk factors for cancer is quite different for each cancer. And so the treatment, the prevention strategy should also be very specific. And so when we talk about cancer, we look at the cancer pattern and trends, we actually look at them separately. All right, so why is cancer so scary? The reason is really cancer can grow and multiply and continue to grow, and then at some point it can invade. And once it invades, it goes into the lymphatic or goes into the bloodstreams and can go to different organs, and that is metastases. So if cancer doesn't spread, then it's really the benign tumor. It's not very scary, but because it has the ability and capacity to spread, so it can be very scary. And this is why it is very important we try to catch it and treat it while it is treatable and relatively small and localized. So I'm using lung cancer as an example. Here is the early stage cancer. You can see there's some cancers here, tumors here. And then, but when it comes to late stage, there are a lot of tumors and they can actually go out of the lung and to become advanced diseases. And so here's stage 1, stage 2, stage 3, stage 4. Therefore, if we want to treat it, we have much higher probability of success if we can catch it early. And this is the concept of early detection, secondary cancer prevention. And we will go into that in a little bit details. Why staging and the size of tumor is important? Because it is directly related to treatment success and survival. If you looked at 5-year relative survival rate for cancer, for early stage, it's 57%. Actually, for stage A1, it could be 90%. But when you wait until stage 4, the survival rate is only 7%. And you see the similar pattern for colorectal cancer. For early stage, 88%. For late stage, is 16%. Therefore, the key for cancer is, even though it's scary, but if we start early, we find it early, it can be curative, and we can minimize the burden and suffering of cancer. I'm going to talk to you about different cancer types. Here is the numbers for US 2025 estimated cancer. Every year, there are about 2 million new cancers diagnosed in the population, about 610 cancer deaths per year. Among men, the most common cancer, this is all races combined in the US, is prostate, lung cancer. The third is colorectal. Prostate cancer constitutes 30% of the male cancer. For female, the most common cancer is breast cancer. The second one is lung. The third is colorectal. For mortality, for men, the leading cause of cancer death among men is lung cancer, then prostate, then colorectal. Not very different from the incidence, the new cases, just a little bit switch of order. For female, it's lung cancer first, and then breast cancer. And the number 3 is pancreatic cancer. These ordering can change almost, not every year, but it can change. It depends on the exposure in the population, screening, and many other factors. But most of the time, they stay pretty constant for several years until there are new exposure or other changes in the clinical system, in screening, or in the population. Liver cancer, liver and intrahepatic bile duct. This is primary liver cancer. Intrahepatic bile duct cancer is cholangiocarcinoma. Liver, hepatocellular carcinoma, and cholangiocarcinoma together is primary liver cancer. This is a very common cancer in Asian American. It is 6% in mortality. It didn't make it to the incidence because it's rare. And in women, it is 4%, and it is the number 7th leading cause of cancer death among women in this country. So the good news, why cancer is scary, why there are good news, I really want to share this with everyone. Over the last 30 years, between 1992 to about now, cancer incidence and mortality are actually falling, decreasing over time. And overall, Asian Americans have lower risk of cancer relative to Caucasian Americans, African Americans, and Hispanic Americans. So keep in mind, cancer is scary, but actually for Asian American, it is not too bad. If you look at the race, this is total cancers from National Cancer Institute data from 1992 to 2022. You can see incidence rates decreasing, mortality rate decreasing. For this total cancer, you can see here are the total cancer rates for each racial ethnic group. Here is the total races combined. Here is the Asian American and Pacific Islanders. In most of the data, Asian Americans are combined with Pacific Islanders because we just don't have enough disaggregated data. This is an area that we Asian American really need to push for so we can have more subgroup and disaggregated data. But you can see for total cancer, for men is 299 per 100,000. For women is 313 per 100,000. And then if you look at here, I'm going to give this to share with you. Compared to white, it is a lot lower because white men has 510, white women has 447. So Asian rates overall is actually lower. Here is the mortality rate. It gives the same pattern. Here is the Asian American rate. It is lower. Actually, it is the lowest of all of the racial ethnic group in this country. However, even though our rates are low, we have actually a higher risk in certain cancers. So we call this disparity from different groups. So for stomach cancer, it's long considered an Asian cancer. And here is the incidence for Asian American, 12.1 per 100,000 in men, 6.9 per 100,000 in women. Compared to Caucasian American, we do have higher incidence. When you looked at mortality, here is the Asian American men compared to white men. We also have 2 times higher rates mortality compared to white men. So stomach cancer is an important cancer for Asian American. Here is another important cancer for Asian American is liver cancer. And also if you look at the incidence rate, it is higher than Caucasian American, but it is almost the same as Hispanic Black and actually is much lower than Native Indians and is also lower than Hispanic American. And actually there is a change in landscape. We published a paper several years ago. About 10 years ago, Asian American would have the highest liver cancer rates, but because there is a lot of active community engagement, ask people to have hepatitis B screening and treatment and all of that. So overall and over time, the rates of liver cancer in Asian Americans actually has dropped. And also because of the obesity pandemic, there's a lot of liver cancer related to fatty liver, and that is more common in other populations. So therefore, currently, liver cancer rates in Asian American is similar to other group. Still is higher than white population, but it's very much similar to Hispanic, Blacks, and other population. And you can see here, our rates are higher than Caucasian American, but is comparable with African Americans. For lung cancer, this is a very important topic for Asian Americans because especially among Asian women. A lot of the lung cancer among Asian women is happen on never smoking women. And so let's look at the rates here. For lung cancer among men, we have 41 per 100,000, which is lower than Caucasian American and Black American, higher than Hispanics. And for mortality, and if you look at women is 27.8 per 100,000, is much lower than Caucasian American. But if you look at mortality here, our mortality is 24 and it's lower, but it is not so much lower. And then for women is 15. Most of the women here is actually never smoking women. So this is a very active area for research among Asian American. So I earlier said we have 40 plus groups. So let's look at the subgroups of Asian American and important diseases related to them. And there's a lot of heterogeneity. If you look at the ranking of all-cause mortality, if you looked at Asian Indian, the number 1 is heart disease, and number 2 is cancer. For this one, cancer is number 1 in Chinese, number 1 leading cause of death in Filipino, Korean, and Vietnamese. But for 2 groups, cancer is number 2. So Asian Indians and Japanese, heart disease is the number 1 cause of death in their population. If we looked at within cancer, for men, for Chinese, because this is the largest group, the number 1 cancer is lung cancer, and then prostate, then colorectal, then liver. For Asian Indian, it's prostate, colorectal, lung, and oral cavity. For Filipino, it's prostate, lung, colorectal, and non-Hodgkin's lymphoma. Vietnamese is lung, liver, colorectal, prostate. Korean is colorectal, lung, prostate, and stomach. And so here you can see lung is very common, colorectal is very common, and then liver is common in certain subgroups, but not all of them. For female, the most common one is breast cancer, and then lung, colorectal, and thyroid. And for Indian, it's breast, uterine corpus, thyroid, and colorectal. Among Filipino women, it's breast cancer, uterine corpus, lung, colorectal. Vietnamese women is breast cancer, lung cancer, colorectal, and then thyroid. For Korean women, it will be breast, lung, colorectal, and then thyroid. So here you see a common theme is breast cancer is most common. And then after that, it's either lung or uterine corpus or colorectal. So these are the common and important cancer among Asian Americans that we need to observe, study, research, and then develop better treatment. But the good news I already shared earlier, but that also applies to various ethnic subgroups. If you look at cancer death rates over time, of course, I mentioned earlier that Asian Americans have the lowest rate. So this lowest rate, this is teal color, blue, actually, is the lowest over time. So for all of the years observed, Asian Americans have the lowest rate, and the rates are declining. And it is declining for most of the population, except for a little bit the American Indian, because the sample size is small, so their rates kind of jump around. But the good news is it's decreasing over time. If you looked at cancer accounts for 27% of all deaths in Asian American. And lung cancer usually is the number 1 cause of death. And cancer is not the leading cause of death in all of the Asian American subgroups, but it is the number 1 leading cause of death, even though our rates are lower than whites, but it is the number 1 leading cause of death for Chinese, Vietnamese, and Filipino Americans. And you can see we already talked about this. It's mostly lung cancer, breast cancer, lung cancer. So these are the cancer that we want to focus on going forward, especially for prevention effort. Risk factors means factors that are related to cancer incidence and mortality. And we can actually divide them into 3 big buckets, 3 big categories. That will be biomedical factors, lifestyle factors, and environmental factors. And here you can see lifestyle factors, there are many, many smaller buckets. And that is actually very good news, because these are, we also call modifiable factors. So we are able to modify that to actually influence one's risks. For biomedical factor, genetic susceptibility, this is the genetic polymorphism that comes with us at birth. So we can quite change it, but we can probably change the expression of this. So through gene-environment interaction, we might be able to change that. But most of these are more stable, much harder to change. Then there's the environmental factors, sunlight, radiation, occupational exposure, and pollution. And a lot of these, we are not able to change it as an individual, but we just need to be careful about our exposure. So you will need to wear protective gears, stay away from radiation, wear something or use your sunscreen. So these are the areas we can change the big environment, but we are able to make some modification to our habits to minimize our exposure. The one in the middle is really the bucket that we as an individual will be able to do some modification to minimize or lower our cancer risk. Smoking, alcohol consumption, physical inactivity and obesity, chronic infections such as human papillomavirus, hepatitis B, hepatitis C, this kind, or H. pylori. So there are certain things that we can do to minimize our risk to these. And then let me move this a little bit. And diet. Of course, these are not very easy to change, but they are modifiable, so we can make an effort to change that to minimize our risk. And this is the interaction between nature and nurture that can influence our risk to cancer development. In fact, 60 to 70% of the cancers can be prevented because we can quit smoking. There's 20% related to obese or overweight that we can try to manage to maintain some ideal body weight. It's very challenging, but it's possible to do. And then there are the cancer-causing pathogens that we can, through vaccination, through eradication, that will be able to influence the risk of cancer. And then there's 5% physical inactivity, dietary habits, and 2% other exposures. So almost about 70% of the risk or the exposures the cancer can be prevented. So here is to share with you the exposure prevalence of these modifiable factors by different racial ethnic groups. So smoking, you can see actually for Asians, most of the risk factors, Asians have much lower prevalence. If you look at smoking, if you look at drinking, actually Asians' rates are lower than the reference group, which is currently here is white. And then there's the physical activity or inactivity, and then there's the healthcare access. It's very similar. I have this bucket here, this box here, because I want to talk about this. Currently, the numbers here are presented using the regular Western BMI cutoff. But if we use, if you use the Western cutoff, you actually can see obesity, BMI greater than 30 among Asian is very low compared to whites. Whites is 32, for Asian Indian is 14%, and 13% for Chinese. But if we use the Asian-specific BMI cutoff, and so that is actually 25 and above, is considered obesity. Actually, the obesity in Asian population is not low. The other thing is we have the sort of the Asian syndrome. The Asian hides their tummy and tummy fat very well. So they could look very skinny, but they actually have abdominal obesity. And this is where the fat is very active. This is where, the metabolic syndrome and insulin resistance and other kinds of things are going on there. And so for Asian, it isn't just for us to pay attention to the body mass index. We also need to look at our waist circumference and also our waist to hip ratio and make sure that we don't have a lot of active adipose tissue around our belly. And so this is a challenge for Asian, because if there's a lot of adipocytes around here and they're much more active, they are also more closer to the vital organs. And also there is a portal vein. So these fatty acids can circulate everywhere and can actually be associated with higher risk, because these fat cells can actually secrete hormones and also inflammatory markers. And so chronic inflammation over time for a long time actually can increase the risk of mutation, increase the risk of cancer. So I think this is an area that we need to work on, especially among Asian Americans. I want to move into cancer prevention, because it is important that when we can prevent it, when there is possible ways to prevent it, I think we should make an effort to do that. Cancer prevention is usually classified into primary prevention, secondary prevention, and tertiary prevention. And health promotion and primary prevention is we do something when there is no disease. Well, you could be at risk, but there is no cancer present yet. So you could have better diet, exercise more, or get better sleep, so to enhance your health and to minimize your risk. Secondary prevention means there's some sort of subclinical disease that you may have some cancer cells, but you don't really have symptoms. You may not really know you harbor some cancer cells. Tertiary prevention is when the cancer is there are symptoms, maybe it's already diagnosed, and we need to take action to treat it or to take it out, just to cure the patients or make them feel better or something like that. So here is when you are healthy, the important thing is to eat well, sleep well, be active, and of course, stop smoking. Then in the primary prevention usually is behavior modification, chemoprevention. It could be something like taking your vitamins, taking your zinc or something, whatever is cancer protective. And then when it comes to secondary prevention, this is early detection of cancer. And usually we call this cancer screening. Then when you have symptomatic symptoms, disease, then it is clinical treatment or chemoprevention to prevent second cancer. So I will actually talk a little bit more about early detection because I am an etiology person. I studied risk factors for cancer for about 35 years, but the last couple of years, I am very passionate about cancer early detection because for some people, they already, when they reach 50, 60, they already surpass this. And so for older people, if they already have certain cancer cells, the best way is for early detection to catch it early and to take it out. So I am very passionate and devoted to cancer early detection over the last couple of years. And here just to show you, when the cells are small and few, it's easy to do something. Once there's metastases, it's beyond control. And so really, we need to get in there early. So I want to talk about cancer screening. One big thing about Asian Americans is the uptake of cancer screening is lower in Asian Americans. We don't really know why. Maybe it's culture related, maybe it's something related, but it is a very important area that we need to understand more. We need to engage the population, the public more to understand. Is it fear? Is it culture? Is it inconvenience? Is it lack of resources? So we can actually develop a system to help people to have the opportunity to have cancer screening. So for cervical cancer, we have pap smear, we have HPV testing, but Asian Americans uptake is low. For breast cancer, we have mammography. It's not too bad, but still it's lower. For colorectal cancer, we have the stool test. We also have colonoscopy. We are also lower. For HPV vaccination, we are slightly lower. For hepatitis B and C, much better because there's a lot of public health work in this area. But overall, in all of the cancer screening modality and methodology, Asians' uptakes are much lower. This is a very poor uptake of lung cancer, low dose CT screening nationwide. We know low dose CT screening can reduce lung cancer mortality by 20%. This is through the screening trial. It's already been validated. But in the country, only 4.5% of the eligible people are doing this. And in California, it's only less than 2%. So the uptake is very, very poor. It's even worse for Asian American. It's only about 1%. And this is low dose CT. It actually, it doesn't cause any pain. It's just people are probably worried about the radiation or something. And we know this works. And so we need to get people to do this, especially if they are at risk. If you looked at lung cancer survival rates by clinical stage, I shared some of this with you earlier. Here is stage 1, 2, 3, 4. The lung cancer survival rate at stage 1A is 92%. At stage 4B is 1%. And so this is why screening and early detection and early treatment is very important. And you can look at the survival rate by stage. So here is stage 4, the orange line, the blue line is stage 1. So anybody, if they are so unfortunate to have lung cancer, it is really better to have stage 1. So we need to encourage people to have physical exam, and also if they are qualified for low-dose CT screening. Last year, we carried out a study called PEARLS, and we asked Asian Americans within the Kaiser system that have they ever heard of low-dose CT screening for lung cancer. 80% of them said they have never heard of it. Our sample size is small, it's only 103. But this information is telling us that we haven't done enough. The clinical community, the epidemiologic community, the public health community, people have never heard of this, even though this works, and it's been working for the last 10, 15 years. And so we need to get out there to share this good news with them. And if people are eligible, we need to find a way for them to have low-dose CT screening. Here are the American Cancer Society cancer screening guidelines, just to share with you. They are effective modality for breast cancer screening, for cervical cancer screening, for colorectal screening. You can do the FIT or you can do other things, and there's colonoscopy, and then for endometrial cancer, for lung cancer. I'm not so sure for prostate cancer. I think this has been revised, and I studied prostate cancer for 30 years, so I don't want to say anything about PSA and prostate cancer screening here. I am going to share this slide deck with you, and so you actually can email CARE and to get all of these information. I will also share resources with you because this is all public information. So you can also go to the ACS website or the NCI website to take a look at if you are eligible, you fit some of these criteria. If you want to be screened, you can talk to your PCP about it. You need to advocate for it. There are also the important cancers for Asian American: liver cancer and stomach cancer. These are currently not included in the national official screening guidelines. But there are things that you can do to understand your risk and take some action. So you can do hepatitis B or viral hepatitis testing, HBV B and HCV testing. You could also, if you have higher body weight, you feel you may have fatty liver, you could actually do an abdominal ultrasound or fibroscan. Then you will be able to see whether your liver have fibrosis or whether you have liver cirrhosis. This is important risk factor for liver cancer. Hepatitis B surface antigen also is a very important risk factor for liver cancer, 20 to 25-fold risk. So you want to know about your personal conditions so you can take actions. These are not included in the national guidelines, but it is included in the national guidelines in some of the Asian countries, but not in the US. For stomach cancer, the important risk factor is H. pylori. So you can do the H. pylori testing, and you could, if you have conditions, for example, if you have gastritis, if you have intestinal metaplasia within your stomach, you can actually talk to your PCP to have endoscopy taken. So it's just, to take a look at inside of your stomach. This may or may not be covered by your insurance, but it's something that you want to think about and then probably figure that out. Here is a guideline. It's not the national guidelines, but it's sort of the guideline is developing. Hopefully, eventually it will be adopted. And this is of the courtesy from Dr. Robert Huang. He is also a CARE faculty. If you're interested, he is an expert in gastric cancer screening. So here are some of the conditions. If you have these conditions, let's say you are immigrants from a high endemic gastric cancer regions, then that would be Korea, Taiwan, China, Japan, some of the Southeast Asia country. Then endoscopy, and or also you also have gastritis. It's probably a good idea to have endoscopy. You just need to figure out how you can get that and how to talk to your PCP about getting an endoscopy. I want to quickly wrap up about what I just said, and so it's not too many bits and pieces for you. Overall, cancer rates are lower among Asian Americans. relative to Caucasian Americans and Blacks in this country. Overall, cancer rates are decreasing over time, and this pattern is also evident in Asian Americans. Cancer occurrence or development is mostly through interactions of nature and nurture, gene-environment interactions. Asian Americans encompass 40 plus subgroups and is very heterogeneous. The leading cancers can vary in different subgroups. So each individual should pay attention to your risk and your modifiable risk factors. And it is really urgently needed for us in the research community and clinical community to have more disaggregated data. I know Latha from CARE is always pushing for this, bless her heart, and we need to work with her to really get better data to better understand the patterns and trends of cancers in Asian American subgroups so we can have more targeted prevention strategy or better effort for treatment. Liver and stomach cancer remain important cancers and high priority cancer in Asian Americans, although the rates are decreasing, but early detection and treatment and detection of viral hepatitis and H. pylori in these populations are important steps that we should take. I didn't show you the data, I just didn't have enough time, but pancreatic cancer is on the rise in most populations, including Asian American, and this is a very deadly cancer. And so we need to pay attention and watch the development of this one. And hopefully we will be able to develop some screening methods because this one is really very hard to catch. Patterns of early onset cancer, I will have a slide or two to share with you. The phenomenon we are seeing over the last 10 years and 20 years is cancer now in the past is a disease of older people, but now it's beginning to develop in younger people. Younger people meaning we call young adult is people who are younger than 50. And we call those early onset cancers. And this is also happening in Asian Americans. And so we need to be vigilant about it, pay attention to it, so we will be able to take action and in a timely fashion. There are several screening modalities that are very effective. I actually share some with you. And so hopefully that you will be able to look into it and use it to lower your risk of cancer. One thing I didn't have time to get into is if you have a family history of cancer, lung cancer, stomach cancer, or any cancer, please pay attention to screening. You may be a perfect candidate for screening. And so if you develop cancer, can be caught early and treated effectively. Here is the paper from 2023 showing that in the US, young people are getting cancer and the rates of cancer in young people, if you're in your 50s or 60s, actually, you know, this is relevant to your children, our children. So people at the much younger age are developing cancer. And here is a slide to share with you. It's 30 to 39 have the highest risk of developing cancer in this group, younger than 49. And Asian Americans also have higher risk of developing early onset cancer compared to Caucasian American. And most of the cancer that is developing in young people, early onset cancer, many of those are in the GI system. Of course, they are the urinary system, female reproductive system, and breast cancer. But many of those are the GI system. And GI cancer actually are usually much more common in Asian American. So for the young Asian American, this is really an area that we have to watch very carefully and quickly develop some action items and actionable plan so we can stop this, because otherwise I think it will be very detrimental to our young generation. And this is the data from 2025. We developed a study, and hopefully we will be funded to study this, but we are watching this rates every year. If you look at this, 0 is really 18 to 49, female is rising very rapidly, male is rising more flat. But for older men and women here is going up a little bit, but for 50 to 60, the rates are falling. For 65, the rates are falling, and female more flat. So we actually need to pay more attention to female cancer, and also we need to figure out what is happening in young people and what can we do for them. So to wrap it up, the take-home message for today, actually, these are the things my grandmother used to tell me. My grandmother was very healthy, and she passed when she was 101. She was always telling me, these are the common sense we already know. Why are you getting so much data to analyze and then tell us the same thing? But she's really true, is do not smoke. Drink just a little or none. Eat well, sleep well, be active, maintain a healthy weight, have a good social network, have good friends, be happy, connect to nature every day, and take good care of yourself, and then follow cancer screening guidelines. This is what she used to say. And she said, I already know, but you spend so much time studying this. So, but she's really right. Yeah. So if you want more information, here are some of the websites from our lab and from our studies. And I put the link here, so you're welcome to explore. And this year we developed the Asian American cohort to study prevention strategies or health information specifically on Asian Americans. So please feel free to come and explore. And then there are other resources very important, relevant to Asian American, from American Cancer Society, and also from AACR, the largest cancer organization. They have cancer progress report every year. So if you're interested, here are the places that you can go. And I would, before I take questions, I would like to wrap up and thanking CARE, because thank you so much for always focusing on Asian American health, and we really appreciate it. And all of the things I have learned, I have shared with you today, is from all of my friends, colleagues, and collaborators from all of these institutes. So I give my thanks to them for this seminar. And then thank you. And I am ready to take questions.
Thank you, Dr. Shing. That was a very informative and very, very helpful talk. We have many questions, and hopefully we have time to go through all of them. I'm glad you mentioned near the end about pancreatic cancer, because one of the questions asked was about why is there such a high mortality rate for pancreatic cancer among the different Asian American subgroups, even though pancreatic cancer itself is not among the top 5 cancers for many of the Asian American subgroups.
A lot of the cancers were very high, we call fatality rate or mortality rate, for several reasons. One usually is the cancer itself is very aggressive. So when you catch it, then it progresses very fast. And so it's very, very difficult to treat, or because for whatever reason, there's no effective treatment. I think for pancreas, it fits all of that, but there's one other issue is it is anatomically it's in a place kind of wrapped up by, liver and all these other organs. And so it's very hard to see and very hard to feel. And so usually by the time that you have symptoms, it's usually pretty late. Yeah. It isn't like prostate or prostate, you could do, rectal digital exam. You cannot feel it, you cannot touch it, right? And so I'm not a pancreatic cancer expert, but that's what I have learned over time is it's aggressive, it's hard to treat, there's no effective treatment, there's no screening, and it's in very difficult anatomical location.
Our next question has to do with risk factors for gastrointestinal cancers, whether it's esophageal, oropharyngeal, stomach cancers. Is there a link between dietary consumption of fermented food in the Asian diet? And additionally, is there a link between aldehyde dehydrogenase deficiency or the Asian flush with gastric cancer, liver cancer, pancreatic cancers?
Probably so, but I'm not an expert in this area. But we do have 2 experts in this area in CARE, so later they can actually supplement more information. I think for the first one, for the fermented food, usually in the past is there could be nitrosamines, and that could actually be cancer causing. But lately, fermented food, through the gut microbiome research, it's actually could be beneficial. So I think probably is the balance, and also depends on exactly what chemicals is in the gut. And so it could be the food itself, and depends on what kind of bacteria, whether it's the good bacteria or the bad bacteria. And that part, currently, I don't have an answer for that. So I think there could be a common elements. And in terms of the AODH, I think AODH too, because Asian has this common polymorphism that we do not metabolize the alcohol and other toxin well. And so that could also probably have some interaction or cumulative effect on that. And that within Stanford Care, Dr. Zhehong Chen is the expert. And so people have this kind of questions, you can send it to Care and we can collate them and later have him respond to your questions, because he actually identified this polymorphism several years ago. Yeah.
Great. And our next series of questions have to do with lung cancer screening. It sounds like right now the screening guidelines are only for smokers. What are some of the ways that people who do not smoke can get screening with low-dose CT? And then additionally, how have we learned from other countries like Taiwan, where they have some data or studies looking at screening for never smokers? Is there any data that we can learn from that?
Okay, so for never smokers, it is not impossible. There are several ways, probably different ways works for different people. You actually can self-pay. When you self-pay, it's pretty expensive, but compared to insurance coverage, so if you do a low-dose CT, and if it's insurance coverage, of course you don't have to pay, but the price for that is very high for the insurance cover CT. I don't know, several thousands. But if you do not have, you're not qualified, you have to be qualified, eligible based on the guidelines in order to be covered, or you need to have indication. Let's say you have nodules or something. But if you are not qualified, but you have family history, I highly encourage you to do low-dose CT. If you have resources, you can actually do self-pay, which is about $500. I mean, it's not inexpensive, but it's $500. If you have family history and you do not have $500, actually, I was told, I haven't really looked into this, I was told Camino Hospital, El Camino Hospital is a community hospital. They have free low-dose CT for people who really need to have it, but do not have resources. But I'm sure there are other procedures you need to go through, but there are ways to do it. And then for some people, I know some of the folks go back to Hong Kong and Taiwan or Japan or Singapore. You can actually do that in those countries. I actually did. I had my low-dose CT in Taiwan, and it was only like $35 US. So you can, if you go there to travel, I think you can also do that. I'm not endorsing this, but there are many ways. And then there is actually currently a study within CARE and also within Stanford Thoracic Surgery Department. Dr. Natalie Louie is running a study for screening for never smokers. So if you're interested, please email CARE to sign up. And then when the study is fully functional and running, I don't know the current situation of the study, but I do know there is a study, then maybe there are opportunities for people to come in for screening. And I think if you're on a study for screening, then of course they should be no cost to you. Yeah. Okay. So get in touch with CARE. And so hopefully, I don't really know how to fix these problems because never smokers currently are not in the guidelines, but I just want to encourage never smokers. If you have family history, if your father, mother, or grandparents have lung cancer, please do consider low-dose CT screening. Yes. That's just my important message today.
Great. And sticking with lung cancer, what are some of the potential root causes for why we're seeing higher rates of lung cancer in never smokers, especially young female patients? Could there be a relation to cooking, smoke exposure in the house? What are some of the thoughts?
Yeah, so there are actually a lot of studies on lung cancer among never smokers in Taiwan by Dr. Yang, who is the PI of Talent. That is the very large study. They screen about 10,000 never smokers. And actually what they found is the rates are not lower than smokers. And then there's CJ Chen, and many people do that. My understanding so far is there are several potential risk factors. They are not completely confirmed. So cooking, yes, the ventilation, the cooking, whatever, the fume, the gas, and all of that could be related. But I was told in their data, the attributable risks, the fraction of the risk is not very high. So that's say maybe 10%, 20%. So it is not the key and dominant risk factors. So it could be in Taiwan, it could be air pollution, it could be asbestos, it could be cooking, it could be many other things. It could also be genetic susceptibility because they define certain polymorphism that will make people more susceptible to lung cancer. Earlier, we were just talking, could it be related to somehow they have weaker lungs? Maybe, whatever exposure they have when they are younger. Could it be related to TB exposure? Because a lot of people in Asia, in the past have certain exposure, and we don't have real good data on that, but these are the things that we are looking into, and and then there is a study at UCSF, Dr. Scarlett Gomez is running a FAN study, and it's exactly to figure out, especially among Asian Americans, what are the important risk factors. So I think in a few years that we will have better data. But right now, these are all sort of the suspected risk factors. They haven't really been totally validated yet.
And have you seen any impact on socioeconomic status and cancer risk, cancer incidence based on the epidemiology studies?
Some of these data are pretty sparse, and they are not always stratified by SES. But based on my experience in most of data sets I have worked with, because a lot of the things we talk about, modifiable risk factors, exposure to the environment, a lot of these are very much related to socioeconomic status. So I would expect that we would see some of that, but whether the magnitude would be really big or whether that would be big enough for interaction or effect modification, that I don't know yet. Yeah.
And I know you had talked about we're seeing rising incidence of cancer in younger population. Is there reasons why that we're seeing earlier onset cancer in younger populations? Is there a root cause, or have we identified a root cause?
Yeah, that was a mystery to us. We actually submitted a grant on early onset cancer last July, and we tried to figure out, we actually cover all of the risk factors. One comes to mind is obesity or junk food, all these things. And so we thought that could be related. But if you think about it more, it could also be something in the environment. It could be plastics, microplastics. It could be endocrine disruptors. It could also be PM 2.5. It could be anything. And so we actually proposed a study that would be able to cover most of these. And so hopefully we will be able to find some specific signals. But currently, it is very difficult to pinpoint a specific risk factor. The only very obvious one, if you look at the trend, is there is a rapid rise of pandemic of obesity. And then, the young people. And then probably is, in our view, is very much related to chronic inflammation. And so could be the factors in the population, in the environment is contributing to that. but specifically which factor, we don't know yet.
And one of the interesting questions that the audience had asked was, are we seeing similar patterns in terms of cancer incidence between Asian Americans living in the US versus Asians living in kind of the origin countries, living in Korea, living in Japan, Taiwan?
For some of the cancers, I would say there is certain similarities. But for some of the cancer, if it's more environment related, for example, when you study the migrant study and you see when they come to the US, their cancer is actually more westernized. Actually, what we see is very interesting. What I show you is Filipino and South Asians, their cancer patterns are a little bit different in terms of the rank and the priority. It's a little bit different from Chinese and Vietnamese. And for Chinese and Vietnamese, they are more infection related, liver cancer, stomach cancer. And then for those two groups, they've been here a little bit longer or something like that. As somehow, and then Japanese, shifted more westernization related cancer. So yes, I think if it's something that you cannot eradicate within one generation, then you will see the similarities. But if something that is modified, for example, the infection, if you don't eradicate, then you will still continue to see liver cancer, right? But then for colorectal cancer and other obesity-related cancer, then when you are in the Western society longer and you adopted the Western lifestyles, then the cancer patterns will probably shift away a little bit from the Asian pattern. But the Asian population in Asia, they are becoming more westernized too, and their cancer are becoming more the Western cancer too. Yeah.
And we'll end with one last question. This is about, tests like GRAL, which is multi-cancer, blood tests. What is your opinion about it in terms of screening, and would you recommend it?
I actually love it, and I'm actually doing it. I actually have a study currently is doing it. I love the concept of it because it's very simple. But I don't know. I hope, I wish, because that's my current study, it will pan out. But there's a lot of challenges because earlier we said one size doesn't fit all, and these cancers have different markers, different etiology. You may need different sensitivity or whatever. But why I'm still doing it? Because I have done studies in Africa for 25 years. Even though I'm very passionate about low-dose CT screening for lung cancer, it's not possible to do that in a sort of low-middle country. Because even if you can buy the CT machine, you do not have enough radiologists to read that. I mean, at Stanford, we're very lucky. We have the best facility. We have the best radiologists, unless later on we can use AI. But so in a lot of the low resource setting, the best modality does not work. And so there needs to be something that's minimally invasive, simple, low cost. And of course, currently these things are not low cost, that we call MSET, MCD, not low cost. But I'm hoping later, we can use just some blood test to find early cancer for early treatment. To me, and also that would minimize people's fear because radiation, MRI, those things, people are scared and they don't want to do it. And actually, a lot of the folks in our survey last year is first, they don't know. And second is they worry about radiation. So if we can just do a blood test, because a lot of people now are comfortable doing blood tests for glucose, for other biomarkers. So I am passionate about it. I love the idea, but I know the challenge because I think this was like 7, 8 years ago, we already started ctDNA at Stanford, right? And right now it is, it is progressing every year. It's getting better every year, but it's not really ready for prime time to be applied to large population scale for cancer early detection. Yeah, so maybe stay tuned. Hopefully we have good news in a few years, but really I feel this is a very important area for all of the populations.
Well, thank you so much, Dr. Shing. I think this was a extremely informative, and we can definitely sense your passion when it comes to this topic. So thank you so much. And I know for the audience, there's a lot of questions that we weren't able to get to. So hopefully we'll be able to collate that and maybe send it out as a separate communication. So everybody, that's it for today. And thank you for joining, and
Thank you for
have a
coming
great night.
in. Bye-bye. Good night.